Good afternoon, everybody. Good afternoon, my professors and colleagues. Now we are going to our head and neck session. We will start with presentation. Hello. Hello, everybody. We are going to start. Okay.
Good afternoon, everyone, and thank you for being there for the head and neck session. We'll begin with my dear colleague and brother, Professor Samer Ahmed, who is leading the MDT in Ain Shams University, who is between the otolaryngology and the oncology departments. And I guess it will be a very interesting tour with a new tour in the head and neck. Please, Professor Samer, go.
Good afternoon. اولا انا عاوز اشكر طبعا قسم الكلينيكال انكولوجي على الدعوه الكريمه دي، وبخص بالشكر جدا زمايلنا في الهيد اند نيك يونت بذلوا معانا مجهود كبير قوي، و we are always happy sharing your activity يعني الحقيقه. My presentation will be about the management of the neck and head and neck squamous cell carcinoma. ما بينقلش. ما بتنقلش بالبريزنتر. اوكي. Actually, at the turn of the century, the WHO has published the 5-year survival rates of different human tumors. And there was a great achievement, an improvement in the 5-year survival rate for the breast cancer, for example, and for the cancer prostate. But unfortunately, this was not the situation in the head and neck squamous cell carcinoma. And the main obstacle for improving the survival and improving the results of head and neck squamous cell carcinoma is actually the presence of the neck lymph nodes. And so, the treatment of the neck is an integral part of head and neck tumors. And neck lymph nodes is the single independent factor, as you all know, deciding prognosis in head and neck tumors. A single lymph node is sufficient to upstage the tumor to stage 3 in most of the classifications. More than 50% of our patients unfortunately present with metastatic lymph nodes at the time of their presentation, of the first presentation. Actually, when you have a single lymph node in the neck, the prognosis decreased by about 50%. If we have bilateral lymph nodes, another 50% less in the prognosis. If you have an extracapsular spread proved pathologically, this is going to further deteriorate survival of about 50%. And if we have fixation of the lymph nodes, actually the 5-year survival will be below 10%. This is actually the instance of the lymph node metastasis in head and neck squamous cell carcinoma. Actually, the T stage and the site are the two main factors deciding which type is going to develop or we have lymph nodes or not. The more the T stage, the more the instance of lymph node metastasis. However, In nasopharyngeal carcinoma and oropharyngeal carcinoma, even in T1, we can find a very high incidence of lymph node metastasis at the time of diagnosis. These are the seven groups of lymph nodes we all know, and we treat according to them. We all know that they are further classified to 1A, 1B, 2A, 2B, 5A, and 5B. We all know this by heart. But reminding you, these are not the lymph nodes in the head and neck. They are not the only lymph nodes. We have other lymph nodes which are not classified in the 7 groups, which includes retropharyngeal lymph nodes, which are very important, as you know, in the tonsillar, posterior pharyngeal wall, tongue base, and thyroid. And also we have the pre-auricular, the post-auricular lymph nodes, and the suboccipital lymph nodes, parotid lymph nodes. All these groups of lymph nodes are not included in the 7 groups. There are 2 landmark studies which has been done lately in the past century, which has changed our practice in the management of the neck, in head and neck squamous cell carcinoma. Here, neck dissection was done to hundreds of patients and was subjected to histopathological examination. And this resulted in defining the preference of every site where it affects a group of lymph node. As we all know, the oral cancer prefers level 1, 2, and 3. These are the favorite sites. For the laryngeal, oropharyngeal, and hypopharyngeal tumors, actually the for the hypopharyngeal, laryngeal, and the nasopharyngeal, the laryngeal, the oropharyngeal, and the hypopharyngeal, level 2 and 3 and 4, as we all know. Level 5 is rarely affected, except as we can see in the nasopharynx and the posterior pharyngeal wall. Also, level 4 is not so much affected, except in tongue base and posterior pharyngeal wall. These 2 landmark studies has changed our practice in the management of the head and neck squamous cell carcinoma, and was the basis on which selective neck dissection was started. These are the bad prognostic or the adverse features in the lymph nodes which worsen the prognosis and needs more aggressive lines of treatment, namely the extracapsular spread, which is associated definitely with less survival. The number of lymph nodes, the more the number of lymph nodes, the more the systemic metastasis, as we all know, and also the level of the lymph nodes, which is not well addressed in most of the TNM staging system. And the Ho's classification of nasopharyngeal carcinoma is the one who is actually defining the level of the lymph nodes. The lower the level of the lymph nodes, the more the aggressive and the worse the prognosis of the tumors. These are the adverse prognostic factors, as you all know. This is the end staging in the TNM staging system, as we all know. This is the 7th edition. In the 8th edition, there are 2 main changes which responded to the prognostic factors we have just mentioned. First of all, the presence of extranodal extension is classified as N3B, whatever the size or the site of the lymph nodes. And for the HPV positive oropharyngeal squamous cell carcinoma, because of the good response of these lymph nodes to chemoradiation, N2A and N2B has been joined to N1. And extranodal extension is not presented at all in this type of oropharyngeal cancer. Actually, historically speaking, the surgery has been classified as the mainstay for the treatment of the neck in head and neck squamous cell carcinoma. We started with radical neck dissection. We removed the first 5 groups together with the internal jugular, sacrificing the accessory nerve and the sternomastoid muscle. But this was associated, as we all know, with a high morbidity involving mainly the shoulder, and that's why modified neck dissection was introduced, preserving mainly the accessory nerve and to a lesser extent the internal jugular and the sternomastoid. With the 2 landmark studies which has been published lately in the past century, selective neck dissection was designed, and it became very successful. As we all know, the supraomohyoid neck dissection were removed level 1, 2, and 3, the lateral neck dissection levels 2 to 4, the posterolateral level 2 through 5, and lastly, the anterior or the central neck dissection involving level 6. Extended neck dissection is actually a neck dissection which removes the 5 groups in addition to the accessory, the internal jugular, the sternomastoid, together with other lymph nodes, for example, the retropharyngeal lymph nodes or other extra lymphatic structure as the carotid artery. Recently, and with the era of organ preservation, super selective neck dissection has been introduced. I'm going to describe it lately in my presentation, but this is a novel type which has been practiced in the late 15 years only. This is a modified radical neck dissection. The three types, all of them are preserving the accessory nerve. But we have to take care that the quality of neck dissection should be decided after pathological examination. At least 18 lymph nodes in these groups has to be identified to get or to define this neck dissection as a good quality neck dissection and to build on the results of the pathology. Now, when you are faced with a patient with head and neck squamous cell carcinoma, we have two possibilities. Either we don't have any neck lymph nodes, that is NO neck, or we can have palpable or radiologically positive lymph nodes, which is actually the N positive neck. Starting at first with NO neck. And when we are faced with an NO neck, one has to answer several questions in treating this patient. First of all, really is it an NO neck? And here the answer is is imaging. And imaging is mandatory because if you are going to describe NO neck, this is a radiological NO neck. These are the three criteria well known in the CT scan which define the metastatic lymph nodes. So it is not a clinically free neck, it is clinically and radiologically free neck. The second question, are you going to treat or you are not going to treat this NO neck? A study from the risk factor groups from Florida, from University of Florida, has been published, which has shown the possibility of occult metastasis in different stages and different sites of head and neck. And all of these has a possibility of occult metastasis of more than 20%. If you have a possibility of more than 20% occult metastasis, you have to treat. If less than 20%, you can watch the patient and follow up the patient. All the head and neck sites, including all the stages, has to be treated because they have a possibility of more than 20%. The only exception is T1 and T2 glottic cancer, where you can watch the patient, and T1 oral cavity. However, a recent meta-analysis done in our department and published recently, comparing between the T1 and T oral squamous cell carcinoma between watching and doing neck dissection, has favored doing neck dissection even for those early oral cavity tumors. But still, you can watch them, no problem. So, you are going to treat the patient, you have two options. Either you have surgery or radiotherapy. First of all, if you are treating NO neck, single modality is more than sufficient. So you have to use surgery and radiotherapy. Unfortunately enough, both of them are equally effective with a success rate of more than 90%. So which of which are you going to use surgery or radiotherapy in the treatment of the patients? This depends on the treatment of the primary. If you are going to treat the primary surgically, like in the oral cavity, you have to surgically interfere with the lymph nodes. If chemoradiation, you have to give chemoradiation to the patient. Now, if you are going to do surgery, which type of surgery you are going to select? We come back to these landmark studies, which gives us the favorable groups of lymph nodes affected in different sites. And accordingly, selective neck dissection can be done for NO neck. For the oral cavity, supraomohyoid neck dissection. For the larynx, hypopharynx, and oropharynx, it is lateral neck dissection, which will be more than sufficient. These are the results of the lateral neck dissection in NO neck with very satisfactory results and very low failure rate, as you can see. This is the results of the supraomohyoid neck dissection in NO neck, which is again associated with a very low recurrence rate, and so it is very effective in treating the patient. So this is if you are going to do surgery for the patient. Are you going to give adjuvant treatment for the patient after surgery? This depends on the histopathological outcome. Definitely if you have adverse features like extracapsular spread, multiple lymph nodes, multiple level, definitely adjuvant treatment has to be decided to the patient, as we all know. Now we come to the other possibility. When you have an N plus neck, you have metastatic lymph nodes starting from N1 ending with N3. Again, the treatment will depend on the treatment of the primary. If surgery, you have to do neck dissection. If chemoradiation, you have to give the patient the chemoradiation as we are going to describe. Starting first with surgery. If you are going to treat the primary with surgery, you have two options. Either you can do selective neck dissection or modified radical neck dissection. For T1 lymph nodes and some selected T2B lymph nodes, we can do selective neck dissection according to the site with very satisfactory results. But if we have higher or larger lymph nodes, N2 or N3, we have to do modified radical neck dissection. These are the results of N1 with selective neck dissection, supraomohyoid and lateral omohyoid. More or less satisfactory results are obtained. And also there is a recently published paper, 2014, giving a very strong evidence that T1 lymph nodes in head and neck squamous cell carcinoma can respond very well for selective neck dissection. For N2 and N3 neck, we have to go to modified radical neck dissection. Actually, we don't use radical neck dissection at all, except in very, very rare situations. That's why modified radical neck dissection is the treatment of choice. You can see multiple studies with acceptable results, with failure rates, which is acceptable in the treatment of the neck for patients with head and neck squamous cell carcinoma. Again, adjuvant or not adjuvant treatment after neck dissection, this depends on the pathology, multiple lymph nodes, more one level, extracapsular spread. The adverse features are going to invite the adjuvant treatment. Actually, the dilemma starts when we are going to treat the primary with chemoradiation. And this is actually the most common situation right now in the era of organ preservation. The response of the lymph nodes is well known to be lower than the response of the primary, in most of the sites at least. And so, theoretically, we have one of three possibilities. Either we can start with neck dissection, and then we go for definitive chemoradiation, what we call upfront neck dissection, or we can have planned neck dissection starting with chemoradiation and then doing neck dissection for all the patients regardless of the outcome of the response of the lymph nodes to the chemoradiation. Or you are going to start with the chemoradiation and to follow up the patient with a good tool that is going to define the residual or the failure rate, and so accordingly you can do salvage neck dissection for those patients who are not responding or having at least equivocal results. Let's start at first with the upfront neck dissection followed by definitive chemoradiation. The advantages of this is that it provides a pathological staging of the patient. So that if you are going to design the treatment for this patient, this will be a good design according to the pathological outcome of the neck dissection. Less complications is expected because the neck is virgin, is not irradiated whatsoever. Don't forget that we all know lower nodal response to radiotherapy compared to primary, and this is especially if you have a large volume like N2 and N3 or hypopharyngeal cancer, where here actually you can start with upfront neck dissection. But the disadvantage is that you are going to over-treat T1 and some T2 small lymph nodes, and also you have the possibility to delay the chemoradiation, because actually the wound healing could be delayed somewhat, and so the chemoradiation could be delayed with an negative impact on the primary. And also we have available accurate tools like PET-CT scan, which is going to define the response of the lymph nodes in most of the cases. For me as a surgeon, it's very difficult to go ahead and do a neck dissection for the patient, treating the secondary and leaving the primary at the same time. For me, this is very difficult to identify, and that's why in our practice in Ain Shams University, we don't do upfront neck dissection. And most of the centers all over the world are not going to do this except in very advanced N2 and N3 and some of hypopharyngeal cancer. Now we come to the other possibility, which is planned neck dissection, where we are going to do neck dissection after completing chemoradiation for every patient, regardless of the response of the lymph nodes. The results was very striking. About 70% of those patients were found to be sterile, with no viable cells, tumor cells in the lymph nodes. Also, some of the tumors like oropharyngeal cancer has given a very good response, even in N3, reaching up to 85%. And that's why you are doing here a lot of unnecessary neck dissections, and the patient can be saved for all its complications. A landmark study we all know of Mahanna, which has been published in 2016, that provided us with level 1B evidence that following up the lymph nodes and assessing the response of the lymph nodes by PET-CT scan after 3 months of completion of the treatment can save us with many unnecessary neck dissections. And so nowadays, the planned neck dissection in most of the guidelines are abandoned at all. We don't do after chemoradiation neck dissection for all the patients. We have to assess the response of the lymph nodes according to the level 1B evidence provided by this landmark study in 2016. And now we come to for giving chemoradiation and assessing the response of the lymph nodes by using a strong tool like PET-CT scan. PET-CT scan, as we all know, is a good negative tool. It has a high specificity, and that's why when it is negative, usually it is negative. Its problem is mainly the false positive results. And so it can be used as a very good negative tool so that you can avoid many unnecessary dissection. Those lymph nodes not responding to the treatment or giving equivocal results by PET-CT scan can go for salvage neck dissection. So this is the most accepted way of treating most of the patient if you are going to have organ preservation. The timing here, as we all know, is 3 months after completion of chemoradiation. And the only exception of this is the HPV positive oropharyngeal squamous cell carcinoma, where we have to wait up to 18 weeks because the response is delayed, and it is a very good response even if you have N3. This is the only exception. Now, if we have failure after chemoradiation, we have to go to salvage neck dissection. First, in the beginning, I have to say that salvage neck dissection is associated with a lot of complications. Up to 50% of our patients during salvage neck dissection has complications. And that's why it is not an easy decision. It is something which has to look very well. We have one of two possibilities. Either you have failure in the primary only and no metastatic lymph nodes are present, or you have a failure in the lymph nodes and the primary is okay. If you have a failure in the primary and the lymph nodes are okay, you are not asked to do a neck dissection. Most of the center, most of the guidelines say it is an optional for the surgeon to do neck dissection or not to do. But we don't prefer doing neck dissection because of the lot of the complications. And also, we have the thesis in our department for those patients after failure of treatment of cancer larynx, where salvage laryngectomy has been done with and without neck dissection, and the results were equal to each other. And that's why, in our opinion, we don't recommend doing an elective or a salvage neck dissection for those patients with no failure in the lymph nodes. But if we do have a nodal failure, here we have to go to the operating theater. We have to go to and have a neck dissection. And you have three options. Either you have modified radical neck dissection where you are going to remove the 5 groups, or selective neck dissection according to the site, or super selective neck dissection. What is a super selective neck dissection? Super selective neck dissection is a type of neck dissection which has been designed for the treatment of the patient after failure of chemoradiation. It is one of the products of the organ preservation era. This is one of the outcomes of it. The super selective neck dissection is a neck dissection where you remove 1 or maximum of 2 contiguous groups, which shows failure in the PET-CT scan. The hypothesis is that why you are going to dissect lymph nodes which responded to the treatment, which has been sterilized, and the lymphatics has been sealed off. And also why to go for dissection of lymph nodes which are not at risk of malignancy. This is a waste of time, and this is exposing the patient to further hazards and further complications. The results are very, very promising, comparable to the selective neck dissection and the modified radical neck dissection. And here, the PET-CT scan is very helpful because it localizes exactly where are the lymph nodes to be dissected by this super selective neck dissection. Now, what is the future of the treatment of the neck? And in the first slide, I presented that the main obstacle against improvement of survival of the head and neck as compared to cancer breast or cancer prostate was the presence of lymph node or failure in the lymph nodes. The future, I think that in the future, the TNM staging system should consider actually the lymph nodes criteria by imaging. For example, if you have a cystic metastasis, these lymph nodes are very good responding to chemoradiation, and that's why they have to be downstaged. On the contrary, if we have a lot of degeneration, this means that these lymph nodes will not respond to chemoradiation and they have to be upstaged. So the future TNM staging system has in one way or other respond to these imaging features which are defined before treating the patient very early. And also, we have to improve the way and the specificity and sensitivity of the tools to assessing the lymph node response after chemoradiation to further avoid unnecessary neck dissection. Some studies are now adding MRI diffusion weighted to the PET-CT scan to improve the specificity and to have a specificity near 95% to have an absolute negative tool which will help you avoiding further unnecessary dissection. Lastly, I have to say that the paradigm is shifting. Surgery was the mainstay for treatment of the neck. in the early days of head and neck cancer. But nowadays, and after chemoradiation, after organ preservation, the response of the lymph nodes is changing. And many of these lymph nodes are responding to this treatment, and surgery is becoming, still it is a mainstay, but one day it will become equal to the chemoradiation, or even the chemoradiation will overcome like in other primary sites of the head and neck. Thank you so much for the presentation.
Thank you, Dr. Samer, for this elegant presentation as usual. And now the floor is open for any questions. Okay, I have 3 comments, please. First of all, I think we have to agree. We have now in radiation oncology different nomenclature for the for cervical lymph node is different from that you are presented in your presentation based on Vincent Gregoire, who is published in 2014 a new classification for cervical lymph node. For example, the supraclavian lymph node is considered as level, it's alone as a group, but now it's considered in our practice as group 4B, which is different from your, I think, also, for example, the retrostyloid lymph node and retropharyngeal lymph nodes now considered as stage 6 and stage 7 and stage 8. So I think we have to find a way to have this same nomenclature for cervical lymph node, so we can understand each other. This is number 1. Number 2, you say that if we have extracapsular extension, it is stage 3B, except if there is single lymph nodes. In this case, it should be stage 2A and not 3B. This is according to NCCN guidelines. Do you agree with me? If it is single lymph node with extracapsular extension, is considered stage 2 N2A. Not.
I may revise it.
Except if you have only single lymph nodes. If it's single lymph node less than 3 centimeters, there's extracapsular extension, it will be considered N2A, not N3B. In the NCCN guidelines, yeah. I think حد معايا رأيكم ايه؟ في الكلاسيفيكيشن هي كده فعلا.
انا الحقيقه ما شفتهاش، هو بس انا شفت الجروبس او السايتس اللي هي اكسكلودد، يعني الاتش بي في بوزيتيف دول اكسكلودد حتى لو فيهم.
لا، ما هو الاتش بي بوزيتيف والنيزوفارينكس ليهم كلاسيفيكيشن مختلف، يونيلاترال او بايلاترال اور اباف او بلو الكريكوي كارتليج. لكن بالنسبه للاكسترا كابسول اكستنشن if there is single lymph node less than 3 centimeter is considered N2A. We can review it.
We can revise it. بس هو فعلا هو دكتور إيهاب even extra capsule spread has been defined يعني in as small as 8 millimeter lymph nodes، يعني can show extra capsule spread. فيعني
آخر نقطة بالنسبة حضرتك في الN0، هو الN0 برضو في عامل مهم معاها اللي هو التي ستيج. يعني لو عيان T1 أو T2 N0 it is better ان احنا نستخدم one modality for treatment. يعني ما اعتمدش ان انا مثلا اعمل سيرجري واعتمد على مثلا الراديشن هو تو eradicate الليمف نود. فهي برضو معتمده مهم جدا ان انا اعتمد على التي ستيج. if you have T1 او T2 N0 ومفيش other poor prognostic factor, so we have to depend on one single modality for treatment, either surgery or radiation. فبس ده اللي انا كنت
يعني هو انا بتكلم بالنسبه للنك مش بالنسبه للبرايمري. يعني
هو حضرتك بتتكلم هنا على lymph node تسبب unknown
مش
origin.
البرايمري، لا البرايمري طبعا هيتعالج.
لا انت بتتكلم هنا المحاضره عن lymph node متسبب unknown origin ولا lymph node متسبب in general؟ المحاضره كانت على lymph node متسبب unknown origin ولا lymph node متسبب in general؟
unknown
الهيد نيك
لا البرزنتيشن was not including unknown origin خالص يعني well known primary with the metastatic lymph node.
فهو لو كانت N0 مهم جدا ان نبص على T1 على T stage. If it's T1 or T2 N0 we have to use only one modality. يعني مش هيبقى فيه اوبشن ان احنا مثلا نعمل هنا سيرجري ونعتمد على الاراديكيشن ليمف نود بس بالراديشن. عشان كده مهم جدا يعني حتى في الاورال كافيتي الانسيدنس ليمف نود متاسس حتى في T1 هي عاليه، فلازم عين دول بيتعمل لهم لو مثلا طنج ليجن 2 سنتيمتر بيتعمل له سيلكتيف ليمف نود ديسكشن.
هو تي 1 كونتروفيرسال يعني تي 1 اوبشنال لحد دلوقتي. الميتا اناليسيس اللي احنا عاملينها ونشرينها في اليوروبيان اركايفز قالت انه برضو احسن النيك ديسكشن بس ستيل ات از اوبشنال يعني تي 1 اورال كافيتي ستيل اوبشنال. تي 2 ما بقتش اوبشنال قوي طبعا، بقى الحاجات الاعلى من كده خلاص ما فيش فيها بقى يعني.
اوكي شكرا جزيلا. Any more questions؟ اوكي هو حضرتك معاك السكيدول بس مش Okay, thank you Dr. Samer for this presentation and now we will move to next presentation.
Okay. Thank you Professor Dr. Samer for this elegant presentation. As a continuation for the important point that Dr. Samer elicited about the importance of imaging, we are going to start the next session with Dr. Manar Mamoun about neck management, about PET-CT and PET-MRI in head and neck cancer.
Good afternoon. First, I'd like to express my honor to be invited in this prestigious conference. I'll talk about PET-CT and PET-MRI that belong to a different imaging technique. How can I move? Sorry. Okay. Sorry. I'll talk about PET-CT and PET-MRI that belong to a type of imaging called hybrid imaging. Hybrid imaging includes two or more different imaging modalities to gain the benefits of both of them and to overcome the limitations of different modalities. In PET-CT and PET-MRI, we include the anatomical data of CT or MRI with the metabolic data of PET to gain the advantages of both of them. The most common radiotracer used in practice is fluorodioxyglucose, that's called FDG, either in MRI or CT. It's a radioactive glucose that's uptaken by any cell that has a high metabolic need. Most of the tumors have high metabolic needs, but we have normal cells in our body that have a high metabolic needs with a high FDG uptake. So reporting doctors should be well aware by the normal uptake. So any other abnormal uptake could be considered as a pathology, whether neoplastic or other. Starting with head and neck squamous cell carcinoma and PET-CT, it's proven that PET-CT is considered the most accurate method and it's a well-established procedure for diagnosing primary head and neck cancer. It has a special importance in occult primary that occur in about 5 to 10% of head and neck squamous cell carcinoma. It's indicated by the National Comprehensive Cancer Network for the initial diagnosis of occult head and neck cancers. In this case, we can visualize, right-sided high FDG uptake lymph node, and you can notice a smaller lesion in the oropharynx that wasn't evident by the contrast-enhanced CT alone. Another case with bilateral cervical lymph nodes and initial negative imaging, we noticed a right right-sided base of tongue, small lesion that's hard to be appreciated on contrast-enhanced CT alone. It's used also for the local staging, depending mainly on contrast-enhanced CT, because it provides us with the anatomical data. In these images, we can visualize the squamous cell carcinoma of the nasopharynx going to the right carotid canal, and the other image shows a nasopharyngeal carcinoma going upward within the intracranial cavity. The perineural spread can appear on PET-CT, but not as PET-MRI, of course. It have to be evident, to be visualized as linear or nodular structure in the expected course of the nerve. Another indication is the second primary malignancies that occur in about 5 to 10% of head and neck squamous cell carcinoma, most often in the neck region, esophagus, and lungs. In this case, you can notice a high uptake within the right retromolar trigone in image A, and there is another separate lesion in the right arioepiglottic fold in image C, and both were proven to be squamous cell carcinoma, giving a diagnosis of synchronous second primary. Another example of second primary with a tongue-based lesion and an incidentally found upper esophageal lesion that was proven to be another cancer. Regarding the nodal staging, the NCCN recommends PET-CT as the imaging modality of choice to detect lymph node leukoregional metastasis. Okay, even if it's small and of no specific criteria, with no internal necrosis, no evident irregular border, the high uptake in suspicious patient is highly suggestive of being a suspicious lymph node. But we should be aware that the spatial resolution of PET-CT is limited to 4 to 6 millimeter. That means that microscopic metastasis within the lymph nodes couldn't be totally excluded by PET-CT. So negative PET-CT for lymph nodes doesn't justify a wait and see approach. And the decision to perform neck dissection will depend on other features such as the stage and histopathological features. Regarding the distant metastasis, it's a recommendation of the NCCN to be the first, for PET-CT to be first-line imaging for distant metastatic workup in suspicious patients. This case of right maxillary adenocystic carcinoma showing right pleural mets in image B. The most common sites of metastasis are lungs, followed by bone or liver, but less frequent. In this case, we can visualize a small lung nodule with a high uptake. But we should note that negative PET-CT regarding the distant metastasis, not the nodal, nearly have 100% accuracy in predicting the absence of distant metastatic or second primary disease. Regarding the post-treatment surveillance, which is the most complex in imaging practice, PET-CT is a validated tool for post-treatment imaging surveillance with a high level of evidence. FDG uptake and SUV measurements have been proven to be accurate for follow-up after chemoradiotherapy or surgery. And the current recommendations by the National Cancer Comprehensive Network guidelines favor follow-up every 3 months for the first year and every 6 months for the second year, and then yearly for, from year 3 to 5. The most recent guidelines strengthening on the point that PET-CT shouldn't be done before 8 weeks. It was 12 weeks and coming now to 8 weeks. Before this period, we can have a false positive result, as in this case, there is a high metabolic activity within a right-sided suspicious looking lymph node. But this was performed on week 5, this patient underwent neck dissection and it was proven to be free. So PET-CT never to be done before 8 weeks for surveillance. Negative PET-CT has a negative predictive value of 90 to 100%. And the most recent guidelines recommend that if we have a positive PET-CT, we should have a further action, either surgery or further biopsy if it's still suspicious lesion or inquiry. It's worthy to mention that NIRADS, our main follow-up diagnostic criteria for head and neck squamous cell carcinoma, are initially developed for contrast-enhanced CT with or without PET. Then it was adapted to MRI. Another indication for PET-CT, but it's not less known, that it could provide us the best and safest route for obtaining additional diagnosis without false result, because we can direct the biopsy site from the highest metabolic active tissue. PET-CT has also a prognostic value because it's proven that the SUV value and the metabolic tumor volume are prognostic indicators, and the higher, the poor prognosis. When to perform PET-CT, to summarize, when we are dealing with unknown primary, when there is a suspicious for metastatic disease, and to plan biopsy. An important information that SUV uptake, that's called standardized uptake value, is the quantification of the metabolic uptake we notice in morphological images. It's called standardized, yet there is no standard value for any tumor or any pathology to differentiate between cancer and other inflammatory conditions. There is no cutoff value between benign and malignant diseases. Consideration that the resolution of FDG PET, as we said before, about 6 to 8 millimeters. So if we have a small nodule, lung for example, less than 6 millimeter, we don't expect the lesion to have a high metabolic activity, and it would be considered suspicious. There are normal tissues that have occasional metabolic activity, like lymphoid tissue in the neck and adipose brown tissue. There are mimickers of cancer on this study as inflammatory lesions. This was a case of naso and oropharyngeal cancer lesion, now presenting post-treatment with a focal high metabolic activity. On contrast-enhanced CT, there is no enhancing tissue, and it was proven to be an ulcerating lesion post-treatment. And unfortunately, we have benign tumors known to have high metabolic activity, such as Warson's tumor. In head and neck, as we all know, there is always a need for a combined assessment using CT and MRI. As in this case, we can notice a huge infratemporal lesion with query intracranial extension on PET-CT, but on MRI, we can notice a frank intracranial extension with cavernous sinus involvement. And here comes the role of PET-MRI that combines the PET study with a full diagnostic MRI imaging. Recent studies compared PET-MRI to PET-CT, and in all studies, it was proven to be very comparable to PET-CT regarding the nodal and metastatic workup, yet it showed higher results regarding the initial local staging and the post-treatment assessment. PET-MRI is advantageous for local tumor staging for the benefits of T2 weighted images, diffusion, and perfusion sequences. Perfusion images performed in head and neck are usually type of permeability imaging that's measured by parameter called K-trans. And it's a known information that MRI is best for tumors of the nasopharynx, sinonasal cavity, skull base, orbit, salivary glands, because these tumors are famous for perineural or intracranial extension, and because we need high soft tissue resolution that's specific for MRI. And contrast-enhanced CT, either with or without PET, is more needed for oropharynx, larynx, and hypopharynx, because intracranial, orbital, or perineural extensions are less common with these subsites, and the patient cannot withstand a long study. Again, good agreement between PET-CT and PET-MRI regarding the nodal and distant metastasis, yet MRI have higher accuracy regarding the local staging and treatment response. These are examples of the papers evaluating PET-MRI. I recommend to read. Another advantage of PET-MRI over PET-CT that in some patients having renal impairment, we cannot give contrast. MRI contrast is more safe compared to CT, but some patients cannot even withstand the MRI contrast. In these patients, MRI would provide us with more information regarding the tumor itself, more than the CT, because it has a high tissue resolution. The clinical applications of PET-MRI are the same for PET-CT, but it's more useful for initial tumor assessment, as in this case, there is a tiny lesion with a high metabolic activity, and it could be visualized perfectly on MRI. We can notice in the upper row image that we can distinguish the tumor from the surrounding muscles on MRI, yet the same pathology, but with CT, we can notice a gray or isodense lesion, and we cannot differentiate the boundaries of the lesion from the surrounding muscles or tissues. Okay. MRI have high performance regarding the perineural tumor spread, orbit, skull base, so PET-MRI would be more beneficial than PET-CT in all these conditions. Example of perineural spread that's visualized in MRI as a linear and nodular enhancement along the course of the main trigeminal nerve, starting from the root entry zone and passing through the Meckel's cave to V2, and there is a high uptake in the corresponding PET images. Example of the usefulness of MRI in intracranial extension that could be hardly appreciated on CT images alone. We can notice a diffuse pachymeningeal tumor involvement. And there is another indication with pachymeningeal mets. Okay. In post-treatment surveillance, it has a high conspicuity of visualizing the disease recurrence compared to PET-CT, because we have the powerful rule of MRI, full diagnostic MRI technique that includes T2, diffusion, and perfusion studies that we usually assess the head and neck with them alone. Another example showing us the usefulness of addition of PET sequences to MRI. In this MRI post-treatment sequence, we can notice a nodular soft tissue enhancement within the right pterygopalatine fossa, and it would be considered suspicious lesion. Yet, this lesion is measuring more than 1 centimeter, so if it is suspicious, I would expect high FDG uptake, but there is no metabolic activity, and it was revealed and it was proven on next follow-ups to be post-treatment changes, free of any tumor. Another example of nasopharyngeal carcinoma that had an extensive skull base involvement, it shows that some cases are very complex for interpretation on imaging, post-treatment imaging surveillance, but PET-MRI in this image shows no remarkable uptake, just the periphery shows mild uptake that corresponds to inflammatory process post-radio and chemotherapy. Another case of right papillary squamous cell carcinoma submitted to tympanomastoidectomy. On follow-up, there is a focal nodular enhancement that was worrisome for any recurrent lesion. But on PET MRI, using the perfusion and PET images, there was no suspicious lesions, and it was proven to be free of any tumor on further follow-ups. An important point that is the chest surveillance by PET MRI. We all agree that CT is the best for chest, yet there is continuous work up for the development of MRI to visualize the tiny lung nodules. Yet MRI is still challenging for tiny lesions below 5 millimeters. Further disadvantage, PET-CT is very fast compared to PET MRI. It's available. The cost is less than MRI, and it has high performance for small pulmonary nodules that are too small to acquire high metabolic activity. Disadvantage, the limited soft tissue resolution and the ionizing radiation. PET MRI, the main disadvantage are the cost and availability, and the tiny pulmonary nodules below 5 millimeters and the longer scan. Yet, it has high resolution, perfect for subsite that needs MRI, and we have the power of diffusion, perfusion, and different MRI weighted images. When to perform MRI, the last point, we perform MRI in patients that we need combined assessment by PET-CT and MRI. So we can combine them in one study, PET MRI. But take in consideration that the patient must be capable of withstanding a long scan. Okay. Thank you.
Thank you, Dr. Manar, for this excellent presentation. And now, if you have any question.
Thank you, Manar, for a very nice presentation. Can we say that we are moving towards PET-CT routinely in head and neck cancer diagnosis?
The guidelines and recommendations favor PET-CT over MRI in surveillance. Yet, personally, I prefer MRI in many situations because we need MRI in oral cavity, in head and neck. But NIRADS was developed initially for PET-CT, and most of the guidelines are towards PET-CT.
For primary diagnosis, I mean.
Primary diagnosis for unknown primary, but not for primary diagnosis itself.
Why not?
MRI has high soft tissue resolution, and MRI have a higher performance regarding the local staging. PET-CT is lower for local staging.
Okay, makes sense. Thank you.
Thank you. Any other question? Okay.
Thanks, Dr. Manar, for this elegant presentation. I'd like to ask about the timing of PET MRI. Should we wait for 3 months as PET-CT for
the same?
The same.
Because it's the same matter. It's the same substance.
Oh, okay, but
the part
MRI, we use MRI alone for follow-up of the patient.
The same preparation for the patient and the same timing are for PET-CT and PET MRI because we use the same substance, which is radioactive glucose. The part I haven't time to present was about another or other substance, just as gallium dotatate. The timing and the preparation is the same for radioactive glucose, but not for other substances that are less known and not used frequently.
Thank you, Dr. Aman.
الكات اوف فاليو حضرتك مره قلتي 4 to 5 ملم، وانا قلت 8 ملم. ايه ال 4 5
لا
ملم؟
مش
الكات اوف فاليو تو ديتكت ليجن اون بيت سي تي. مره قلت 4 to 5 ملم، وانا قلت 8 ملم. امتى تبقى دي وامتى تبقى دي؟
هو في البات سي تي انا عندي اتنين، عندي بات وعندي سي تي. البات سي تي هيوري ليجن، السي تي لوحده هيوري الليجن لو 2 أو 3 مللي عادي. البات هو الميتابوليك اكتيفيتي ما بيظهرش في الليجنز اللي اقل من 6 ل 8 مللي، يعني الرقم. لكن يعني قوه البات سي تي عن البات ام ار اي في اللونج نوديولز ان انا بقدر اشوف ان في نوديول راوندد سسبيشس في السي تي ايمج، حتى لو لسه ما وصلتش للسايز اللي هياخد فيه ابتيك. لكن البات ام ار اي مش هيوريني النوديول 3 ل 4 مللي، هي دي النقطة. لكن الليجن اللي أقل من، يعني هو كان بيتقال سنتي، بعد كده الأمور بتتقدم شوية بشوية. يعني الستاندرد دلوقتي إن الليجن اللي أقل من 8 مللي هي اللي صعب تاخد أبتيك، حتى لو هي فيها ماتس أو فيها باثولوجي.
شكرا.
And now I'd like to introduce my dearest colleague, Dr. May and Dr. Nancy Torre, to present cases from head and neck unit to be discussed.
Good evening. It's my honor to present a case today in our 10th Clinical Oncology Conference. I'm Nancy Torre El-Wasli, Lecturer of Clinical Oncology in Shams University. Today our case is 60. Our case is 16-year-old male Sudanese patient, medically free. His condition started in February 2022 with nasal obstruction, epistaxis, and left neck mass that was painless, lemon-sized, progressive course with no other masses felt in other sites and no accompanying symptoms. Patient sought medical advice while his examination showed bilateral limited lateral eye movement, tongue deviated to the left, angle of mouth deviated to the right, left cervical neck swelling around 3 cm, hard, mobile, and painless. Patient was advised to do CT paranasal sinus with contrast that showed large ill-defined nasopharyngeal mass 4 by 5 by 6 cm, infiltrate skull base, eroding basis phenoi, clivus, and posterior choana. MRI nasopharyngeal neck with contrast was recommended that showed heterogeneous mass 9 by 8 by 6 cm that extend anteriorly to the nasal cavity, and that was here. While posterior to the left prevertebral muscle and left cerebellopontine angle compressing medulla oblongata, as we all see here also. Superior to skull base infiltrate clivus with intracranial infiltration of pituitary and posterior wall sphenoid sinus, while inferiorly to oropharynx, as we see here, the craniocaudal extension. Laterally to parapharyngeal space, left medial trigoid muscle, completely compressing left carotid space. As regard the cervical lymph node, multi-level bilateral upper and lower cervical lymph node, largest on left side at level 2, 2.7 cm. CT chest with contrast was free as a metastatic workup, while bone scan just show uptake related to the site of nasopharynx. Biopsy is recommended, endoscopic guided biopsy that showed invasive squamous cell carcinoma grade 3. So it's likely nasopharyngeal squamous cell carcinoma with clinical staging T4N2 stage 4A. At this point, what's your opinion about the best management for this patient? To start with chemoradiotherapy or to start with induction chemotherapy? For us, we started with induction chemotherapy 3 cycles based on Zangital 2019 3-cycle gemcitabine cisplatin given as induction chemotherapy, added to chemoradiotherapy, significantly improved recurrence-free survival and overall survival as compared with concurrent alone among patients with locally advanced nasopharyngeal carcinoma. Follow-up MRI nasopharynx showed, according to modified RECIST criteria, the patient is unfortunately still stable disease. So, at this point, what's your opinion about the next step in this patient? To consider chemoradiotherapy, to consider second-line chemotherapy. According to the previous mentioned study protocol, our committee advised to give concurrent chemoradiotherapy with cisplatin every 3 weeks with IPID to be done twice weekly and recontour after 50 gray to assess the response. Our patient underwent dental examination, audiometry, and nutritional consultation, after which patient underwent CT simulation with contrast. MRI fusion was done for optimized delineation, while patient received IMRT with definitive intent, 70 gray in 33 fraction, conventional fractionation, simultaneous integrated post, 5 fractions per week. And as it's expected, due to extensions of the tumor, that we just under coverage related to the brain stem, we accepted the coverage to be 90% at these points, as we just reached the maximum tolerance of brain stem. And that was the points accepted to be covered by 90%. And this was the coverage of 95% PTV of 60 gray. According to the DVH, as it's expected, we reached the maximum tolerance of most of the organs. The PRV of the cord was 50 gray, brain stem was 58, optic nerve, left and right were 51 and 52, whereas it's expected we sacrificed both parotid glands. Our patient received radiotherapy as planned till 50 gray, recontouring was done, showed nearly stable disease. So we continued to 70 gray, which he finished 2 weeks ago and advised to wait 4 more weeks to assess response. In your opinion, if the patient achieved complete response after chemoradiotherapy, can we consider adjuvant chemotherapy knowing that the patient received induction chemotherapy previously? Yes or no? In 2021, Yupa Shen et al. Conducting phase 3 study demonstrated significant improvement of failure-free survival at 3 years from the use of 1 year of low-dose capecitabine metronomic following definitive treatment and when patient achieved complete response. The vast majority of patients treated in this study had received both induction chemotherapy and concurrent chemoradiation, supporting this adjuvant approach even in patients heavily pretreated with sequential chemoradiation. Thank you.
Thank you. Thank you, Dr. Nancy, for this excellent presentation. Dr. Ihab has a question. Okay. Discussion will be at the end. Please, Dr. May.
It's my honor to discuss this case with my professors and colleagues. I'm May Atif, lecturer of clinical oncology in Ain Shams University. My patient's 56 years old male patient, heavy smoker, negative family history with no comorbidities with ECOG1. Condition started in October 2022 with hoarseness of voice, however, neglected his complaint till he developed stridor in September 2023 and emergency tracheostomy was done. Laryngoscopy showed irregular supraglottic swelling more prominent on the right side. Both vocal cords showed restricted mobility. Glottic structure could not be visualized with query extension of the supraglottic swelling. Subglottic area could not be assessed. Multiple biopsies taken where pathology revealed right vocal cord mass, left vocal cord mass, anterior commissure mass and subglottic stenosis all show moderately to poorly differentiated squamous cell carcinoma. Preoperative imaging showed CT chest showed solitary left ground glassing pulmonary dual 3 mm in diameter. CT neck and pelvic abdomen with contrast showed the large transglottic mass invading right epiglottic, left area epiglottic, and glottic folds, causing marked narrowing of airway measuring 4.5 and 3.5 centimeter with invasion of thyroid cartilage. Multiple bilateral cervical lymph nodes, largest at the right side. Level 2A was the largest, 2.1 centimeter. Tracheostomy tube seen in place, right thyroid lobe showing hypodense lesion, 2.3 times 1.6 centimeter. Multiple vertebral hemangiomas. Patient underwent total laryngectomy, thyroidectomy, right submandibular gland, and bilateral lymph node dissection. Total laryngectomy specimen showed unifocal midline and right midline and left transglottic mass with greatest dimension 4 centimeter, undifferentiated squamous cell carcinoma. P63 was done showing positive staining with lymphovascular invasion and perineural invasion. Right and left posterior mucosal and soft tissue margins are infiltrated by the tumor. Left anterior soft tissue margin is free of malignancy apart from lymphovascular emboli. The lower tracheal and superior soft tissue margin, right and left ariepiglottic fold margins, right anterior soft tissue margin, right and left lateral soft tissue margins, right and left piriform fossa are free of malignancy. The tumor infiltrates the inner and outer cortex of thyroid cartilage, cricoid cartilage, thyroid gland, and posterior soft tissue, including muscle bundles. Lymph node dissection, right side group 2, 3, and 4 was dissected. 5 out of 7 lymph nodes were positive. 1 lymph node shows metastatic deposit of papillary thyroid carcinoma. The other revealed the undifferentiated squamous cell metastasis deposits without extranodal extension. Left side group showed 3 positive for malignancy out of 8. 1 lymph node shows again metastatic deposits of papillary thyroid carcinoma. The other reveal undifferentiated squamous cell metastatic deposits with extranodal extension. Paratracheal lymph nodes were negative for malignancy. Right submandibular gland excised and showed positive for malignant extension. Therefore, the pathologic stage of this laryngeal carcinoma was T4A, N3B, stage 4B. Thyroid gland was dissected. Left lobe of thyroid gland revealed 2 foci of papillary thyroid microcarcinoma measured 0.3 centimeter times 0.2 centimeter. Right lobe of thyroid gland revealed a focus of papillary thyroid carcinoma measured 2.3 times 2 centimeter away from thyroid capsule by 0.1 centimeter. Immune histochemistry HbME1 showed positive staining of papillary thyroid carcinoma. Pathologic stage of the thyroid carcinoma was T2N1B, stage 4A. This is what we say, it's a collision tumor. The term collision tumor refers to the coexistence of 2 histologically distinct malignant tumors within the same mass. Occurrence of multiple primary malignancies is not uncommon fact in oncology. Rates between 2% and 10% have been described in autopsy cases. while metastasis of upper respiratory tract by thyroid carcinomas has been reported to occur in 0.9 to 22% of patients, and thyroid gland invasion is reported in 30% of laryngeal cancers and 12.5% in hypopharyngeal cancers. Collagen tumors involving thyroid and neck region are especially uncommon, with most reported cases involving papillary thyroid carcinoma in coexistence with medullary thyroid carcinoma, follicular carcinoma, and metastatic disease. The latter including a rare occurrence of metastatic liposarcoma and thyroid papillary. A collagen tumor of papillary thyroid carcinoma and squamous cell carcinoma primary to the thyroid has also been reported. The association of primary upper respiratory tract and thyroid cancer seem to be very rare. Only case reports found for papillary thyroid carcinoma associated with laryngeal squamous cell carcinoma. Multiple primary malignancies should always keep in mind in head and neck tumors. For this reason, larynx, nasal cavity, nasopharynx, oropharynx, hypopharynx, trachea, and bronchus, esophagus, auricular, parotid gland, face, and all head and neck regions should be examined in larynx carcinomas. Due to the rarity of collagen tumors of the head and neck, it is difficult to determine their etiology. Two hypotheses have been suggested. The first suggests that the two primary tumors develop in the same location by chance, perhaps due to radiation. The second hypothesis suggests that presence of the first tumor alters the microenvironment, allowing the second adjacent tumor to develop. Could you suggest any further investigations for this patient? Of course, thyroglobulin and antithyroglobulin antibodies for this patient is indicated. Post-operative serum thyroglobulin on thyroid hormone therapy or after TSH stimulation can help in assessing the persistence of disease or thyroid remnant and predicting potential future disease recurrence. The thyroglobulin should reach its nadir by 3 to 4 weeks post-operatively in most patients. In multivariate analysis, the post-operative thyroglobulin is often found to be an independent predictor of persistence or recurrent disease. So will it affect our decision of treatment of this patient? Of course, thyroglobulin, it will differ the management of the thyroid case if it's high or low. If it's high, will be a remnant or metastatic disease. So mostly we will need post-operative neck ultrasound so to be sure that all there's no remnant pathological lymph nodes. But our question now to our surgeon, will you go for another surgery for this patient if we found positive lymph nodes?
Bilateral neck dissection for the squamous cell carcinoma of the larynx. However, the number of the lymph nodes are not satisfactory في كانوا 6 و 8 تقريبا one side. فwe can consider this بس طبعا يعني برضه هنعمل التراساوند ونشوف الدنيا اناتوميكالي عامله ازاي، يعني ده بايوكيميكال لكن اناتوميكالي الدنيا عامله ازاي برضه وي هاف تو اسك فور ذا اناتوميكال فايندنجز اللي موجوده، يعني لانه ريفيجن نيك ديسكشن فيها مشكلتين طبعا، ريفيجن وتاني حاجه بقى الادجوفنت تريتمنت اللي هنديه ممكن بقى يبتدي يتعطل، مش عارف يعني هنبتدي نستنى نعمل نفس القصه بقى نبتدي بنيك ديسكشن ولا ناخد الكيمو راديشن، لان احنا عندنا تو برايمريز واعتقد الابر هاند للسكوما سيل كارسينوما بتاعت اللارنكس يعني برضو بالاوبورتيونيتي لا يعني الكيلر اكتر هو السكوما سيل كارسينوما والادفانس اكتر، الثاني يعني واز ديسكفرد اكسيدنتال ديسكفر، يعني واحده لوب كان مايكرو كارسينوما ولوب ثانيه كانت برضو تي 1 ما كانتش معديه قوي، فيعني برضو البرايورتي اي ثينك ويل بي فور ذا laryngectomy او يعني فور ذا كانسر لارynx، ويعني الليمف يعني اعتقد ان النيك مانجمنت للليمف نودز دي هتبقى ديبندنت على الاناتوميكال فايندنجز لو كانت سترايكنج قوي يعني.
Allow me, Professor, to ask you for another. As you said, the squamous cell, laryngeal squamous cell carcinoma is take the priority in treatment because it's the worst prognosis in this case. This patient is positive margin.
هو برضو I have to comment for the margins.
Yes.
التوتال laryngectomy margins are very surprising اللي اتكتبت دي. يعني ايه الانتيريور margin is positive؟ I don't understand as a surgeon what is the anterior margin. Anteriorly is the strap muscles ودي بتتشال already مع السيرجري. Superiorly is the epiglottis ودي موجوده في الهواء. Posterior margin ممكن I can accept ان مثلا يبقى في حاجه، بس طبعا يعني ساعتها كان هيبقى في حاجه بوست كريكويد، يعني ان البوزيتيف anterior margins دي يعني بالنسبه لنا ملهاش explanation anatomical يعني قوي. يعني الحاجه الوحيده
patient operated outside our
يعني اقصد اقول الباثولوجيست بيبقوا معذورين، لانه الباثولوجيست في معظم دول العالم بيبقوا يا اما نشرح لهم كويس السبيسمن يا اما واقفين معانا في اوضه العمليات، عشان احنا دايما يعني مثلا كتير قوي مثلا ايبيجلوتس في الهواء يكتب عليها superior margin is positive ودي موجوده في الهواء. الانتيريور مارجن في التوتال انجكتوري ده يعني حاجه، الانتيريور اللي ما فيش غير ستراب ماسلز دي اوريدي بتتشال واللارنكس مقفول على بعضه. هل هي بقى سكين؟ يعني مش مفهومه قوي حكايه لكن بقى الاذر ادفيرس فيتشرز ممكن نعتبرها، انما البوزيتيف مارجنز دي انا يعني اي دونت بليف خالص في ان اناتوميكالي ما تجيش يعني. لكن الاذر ادفيرس فيتشرز كلها يعني بتالي suggesting adjuvant treatment يعني.
of course. Thank you, Dr. Sam. Will we recommend whole body iodine scan for this case so that if the thyroglobulin is high, to see if there is remnant for the thyroid tissue or lymph nodes?
I think for this patient, we should start adjuvant radiotherapy within less than 6 weeks. Then we will proceed for adjuvant radioactive iodine. Those will be a high dose, yes.
Thank you, Dr. Riham. If thyroglobulin is low, all the problems are solved, and in ATA low and intermediate risk patients that didn't receive radioactive iodine remnant ablation in non-stimulated post-operative, thyroglobulin less than 1 nanogram per milli was associated with excellent clinical outcomes and recurrence rate less than 1%. Our patient, thanks God, thyroglobulin was 0.12 and antithyroglobulin was negative, and patient is ATA intermediate risk group. Do we need further investigations for these patients? I mean, rule of FDG PET-CT in this case. My question is to Dr. Manor. Please, the mic, I can't hear you.
3 millimeter long nodule will not appear as a metabolically active lesion in PET-CT, but you can follow up.
Yes.
For the thyroid lesion, as far as it takes iodine, there is no need for PET-CT. The PET-CT for differentiated thyroid cancer with negative iodine despite elevated thyroglobulin, and for anaplastic. Okay.
Thank you, Dr. Manar. As Dr. Manar said, role of PET regarding our patient thyroid carcinoma, differentiated tumors with iodine avidity have low glucose metabolism, with the converse being true. Therefore, FDG PET-CT advocated as monitoring procedure for patients with high-risk disease, adverse histology, columnar cell, tall cell, insular variants, Hürthle cell carcinoma, follow-up patients with elevated TG but negative whole body iodine scan. Rule of PET regarding our patient laryngeal carcinoma in malignant benign differentiation of solitary pulmonary nodule with diameter of more than 1 centimeter, PET-CT plays an essential role. However, for nodules less than 1 centimeter, and now Dr. Manel showed in the previous presentation, it reached 5 centimeters in diameter, PET-CT is unsatisfactory. 5 millimeters, sorry. Plan of management, which comes first? Dr. Riham answered that NCN recommended that the preferred interval between resection and post-operative radiotherapy should be less than or equal to 6 weeks, while delayed initial radioactive iodine therapy beyond 3 months, but no later than 6 months, didn't impair short-term clinical outcomes or long-term overall survival for patients with differentiated thyroid carcinoma. This is a systematic review summarizing articles from January 1995 to February 2022 that investigated the influence of time delays between surgery and post-operative radiotherapy on prognosis in head and neck cancer patients. NCN guidelines are well known for all of us that these patients T4 M positive with adverse pathological will go for concomitant chemoradioadjuvant therapy. Papillary thyroid carcinoma management, iodine is generally cleared within 4 to 8 weeks in most patients, so concern about iodine burden from IV contrast that the patient took in radiotherapy planning causing a clinically significant delay in subsequent whole body scans or radioactive treatment after the imaging followed by surgery generally unfounded. When there is concern, a urinary iodine to creatinine ratio can be measured. And this is the classification of this patient in ATA, low to intermediate risk group, and adjuvant radioactive iodine is highly considered for this patient given his old age. And this is the ATA clinical decision-making and management recommendations in intermediate differentiated thyroid carcinoma patients that have undergone total thyroidectomy. Thank you.
Thank you, Dr. May, for this interesting case. And now floor is open for discussion. Any question?
هو معلش بالنسبه للحاله الاولانيه بتاعت النيزوفارينكس دلوقتي يبقى مهم جدا ان احنا نعمل الابشتاين بار فيروس لان ده بيفرق في المانجمنت. الابشتاين بار فيروس مهم قوي لان هو بور بروجنوستيك فاكتور في النيزوفارينكس.
هو unfortunately it's not available in our pathology department.
وده هيفرق في السلكشن بتاع الكيموثيرابي لو حضرتك حبيتي تعملي اندكشن كيموثيرابي، لان في ناس بتستخدم لو هو بوزيتيف ممكن تستخدمي جيمسايتابين سيس، لكن لو هو نيجاتيف ممكن تستخدمي جيمسايتابين سيس او التي بي اف، يبقى ده الاندكشن. ولو استخدمت اندكشن كيموثيرابي ومع بعد كده كونكرنت كيمو راديشن مش هتعرفي تستخدمي كأدجوفنت بعديها ببلاتينم، هيبقى صعب. الزيلودا لوحديها ما ثبتش انها افكتيف في على الاوفر اول سرفايفل. هو تقريبا ثبت انها جاست في البروجريشن فري سرفايفل، لكن ما ثبتش ان هي افكت على الاوفر اول سرفايفل، فالمينتننس بتاع الزيلودا هيبقى صعب. فمهم قوي ان احنا نعمل الابشتاين دي اذا كان يعني جاست الناس عشان تبقى عارفه يعني ان الابشتاين باي فيروس مهم قوي في الحالات دي. دي بالنسبه للحاله الثانيه بتاعت الكانسر ثيرويد. معلش كنت اسال هو البيشنت عندها كام سنه؟ هو بيشنت ميل ولا فيميل؟
ميل بيشنت.
كم؟
ميل بيشنت
عنده كام سنه؟
65 years old.
65 years old. طب هل كان معلش هو الديجري اوف ديفرنشيشن بتاع البابيلاري ثايرويد كارسينوما كان عامل ازاي؟
معلش مش
degree of differentiation
moderately differentiated.
كم؟
moderately differentiated.
مش poorly differentiated.
No, not poorly differentiated.
لأن في بعض الأحيان ساعات لو especially لو كانت poorly differentiated أو undifferentiated أو ممكن يحصل de-differentiation للانابلاستيك فورم. وفي بعض الأحيان لما تكون انابلاستيك بيبقى مهم جدا إن أنا أشوف هل ده invasion من المالجنانت كانسر لارينكس انتو الثيرويد، خاصة ان مع كل الدايليما دي والعيانة عنده ليف نود ميتاستاز. انت كاتبه ان البوست اوبرتيف ثايرويد جلوبولين كان طالع 0.1 او 0.2.
يس.
فهو اعتقد ان مهم قوي ان احنا كنا نعمل اميونوهيستوكيمستري عشان يتاكد ان اللي كان موجود في الثيرويد ده مش انفيجن فروم اوتسايد من اللارينكس انتو الثيرويد جلاند.
هم طلبوا ال HBM1 والبي 63 وهو اكشولي البيشنت ده عنده الاثنين.
63 ده هيطلع ده سكويمس.
ده for the squamous and the other one for the thyroid ال HBM1 and HBMI1 and the patient has the laryngeal tumor is invading the thyroid and the accidentally discovered pulmonary 2 centimeter nodule. Of course, when the patient comes to us, we revise the pathology.
اللارنكس invading الثيرويد.
Yes.
كانسر لارنكس invading الثيرويد.
Yes.
بدليل ان هو ده اعتقد هو طلع من الاستراب ماسل ودخل على الثيرويد وده السبب في انها كانت بوزيتيف مارجن.
Yes.
فخلي بالك انا اعتقد ان اللي في الثيرويد ده انفيجن من اللارنكس مش.
But there were 2 positive lymph nodes.
وليمف نود ميتاسيس ده حوالي كانوا كتير ليمف نود ميتاسيس ليمفوم بابيلري وكل ده وبوست اوبرتيفلي الثايروجلوبولين less than 0.1 صعب شويه.
Of course, revision of pathology will be done.
خلي بالك ان عيان برضو ال 65 سنه دي يعني تخليك برضو ايه كوشس ان العيان ده غالبا يعني نحط دي في دماغنا يعني. وطبعا الاهميه هنا للكانسر لارينكس لان هو ده المور فيتال وبعد كده تبقى للراديو اكتيف ايودين اللي حابين نستخدمه يعني. شكرا.
Thank you, Dr. Ian.
I have a question in the first case, Dr. Nancy. The pattern of response to the induction chemo and to the concurrent in the second phase is not classic with squamous cell carcinoma. Do you have an explanation for this?
No, we didn't have an explanation for this. Yeah, I accept with you that it's something weird that we don't see a lot. Maybe it's like Dr. Ihab said, it's related somehow to Epstein-Barr virus. Patient is Sudanese. But we see here that the patient didn't respond to our treatment well. We don't have any more explanation.
Did you consider rebiopsy of the lesion after the first reevaluation? Rebiopsy.
Rebiopsy? Yeah, it's an option if the patient, after a total assessment, after 6 weeks from concurrent still stable disease, yeah, we can consider doing PET-CT after total 12 weeks. If still patient has that huge residual, yeah, we can go for a new biopsy. Yeah.
Yes, I have a small comment because the pathology seems to be chemo and radio resistant. And from what I remember from the trial, the incidence of non-responders to GEM-CIS was less than 5% or so. And to the total treatment, it was even less than 2%.
Yeah.
So the condition is extremely weird.
I accept with you, but we have confirmed pathology revised that the patient is squamous cell carcinoma, so we have no other option. He received chemo and received concurrent.
هو برضو حته مهمه قوي ان قلت انها سودانيه. خلي بالك المرضى السودانيين بالذات لو كانوا من ناحيه الجنوب الشرقي في المنطقه دي بتاعت جنوب شرق السودان وجيبوتي واليمن والصومال الابشتان فيروس هناك انديميك. يعني كنا بنشوف كميه بركه ليمفوما نيزوفرينجيال كارسينوما في الناس دي اعداد رهيبه. يعني من كل مثلا 10 عيانين بيبقوا 8 منهم عندهم لا اما بركه ليمفوما لا اما نيزوفرينجيال كارسينوما منتشر جدا هناك.
Thank you all. Now we have reached the end of our session. Thank you all for attendance and participation and discussion. Thank you.